Bariatric surgery is a term that encompasses all forms of weight loss surgery. This mainly falls into three groups. One, restrictive surgery, where in some way the stomach is made to seem smaller so that less food can be taken. Two, malabsorptive surgery, where less food is absorbed. And three, a mixed group somewhere between. The commonest types of surgery are gastric banding. This is a restrictive procedure where a silicone band is placed on the upper part of the stomach so that only a small portion of the stomach lies above the band. This band can be adjusted to get the fit just right for the patient. If a patient eats too much, then food will either be regurgitated or they will have discomfort that slows their eating. The second common form of surgery is gastric bypass surgery. This is what we call a mixed form of surgery, and it involves both a restrictive and malabsorptive component. The stomach is divided high up, so only a small pouch of stomach is left, and food passes through this, and after division of the bowel and reconstruction as a Y-shaped anastomosis, the food passes from that pouch straight into the bowel, and the juices from the digestive system of the bile ducts and pancreas join that food later to help with absorption. The third type of surgery, which is increasingly maybe seen, is a sleeve gastrectomy. In this type of surgery, which is restrictive, the outer 2/3 of the stomach are removed, leaving only a very thin amount of stomach based on the lesser curve. Lastly, we sometimes use the intragastric balloon. This is a 500 to 600 ml balloon which is placed endoscopically in the stomach. This gets a moderate amount of weight loss which can only be sustained for about a 6-month period, and therefore we tend to use it in larger patients as a preoperative means of weight loss to decrease potential mortality and morbidity of surgery. There are a number of well-recognised international indications for the use of bariatric surgery. These are very much mimicked by the National Institute of Clinical Excellence guidelines. They are that the patient should be of a BMI over 35 with obesity-related comorbidities, or to have a BMI over 40. That patient should have completed the usual expected conventional treatments, including trials of medications where appropriate, and should have been appropriately assessed by a nutrition team with an interest in access to bariatric surgery. Of course, because of capacity reasons, many local regions may have their own thresholds for admission, and you'd have to check this with them. The contraindications for surgery include alcohol or drug dependency, being unfit for anaesthesia, or having uncontrolled major psychiatric illnesses. Patients with learning difficulties who would be unable to understand or comply with the weight loss programs would also be ineligible. Relative contraindications include well-controlled psychiatric illness and binge eating, which is a particular problem for us. If patients are binge eaters, then although it is likely that they will do less well with weight loss surgery than those who are not, it still probably or often is their best option. It's important to note that there are limitations to the benefits we can get with weight loss surgery. It must always be thought of as a tool to help with weight loss rather than an absolute cure by itself. All patients will have lifelong dietary restrictions, and all treatments must be lifelong. We know that however well someone does for however long, if the surgery is undone, unfortunately they will regain their weight. Patients should also know that there is a limit to how much weight they can lose. As a general rule of thumb, 75% of patients who have weight loss surgery will lose approximately half of their excess body weight. That's their weight above their ideal weight, and keep it off for about 10 years. This has been related in Swedish studies to about 20 to 30% of overall weight loss at 2 years, which is reflected by a persistent 15 to 25% weight loss by 15 years. All patients should be enrolled in a lifelong project of follow-up, because we know once more that patients who attend for follow-up are likely to do better and have fewer complications.